Good afternoon, everyone. I'd like to thank the conference organizers for inviting me to do this talk, which is about what is needed to create affordability hepatitis C virus treatment and diagnostics. Well, as you've already heard, this is an absolutely massive problem with nearly 750,000 people dying each year from hepatitis C. So a problem this massive absolutely requires a strategy to deal with it. And that strategy is best suited to a public health approach, I think even in high resource settings, as well as low and middle income countries. So this approach entails simplifying diagnostics, pre-treatment assessment, monitoring during and after treatment, and treatment itself. You also need a target product profile for an interferon-free regimen. This would include addressing concerns about affordability and both the gaps in knowledge and the limitations that we are aware of involved with direct-acting antivirals. I also want to talk about what's in the HCV pipeline and how it can inform treatment strategies and sequencing. So as you've heard, oral direct-acting antivirals have radically simplified hepatitis C virus treatment. Cure rates have topped 95% in many clinical trials, and while they drop a little bit in real life, they're still remarkably high compared to peg interferon and ribavirin. And these drugs are safe and tolerable. In a lot of these clinical trials, even with ribavirin, the adverse event-associated discontinuation rates were less than 3%. And because these drugs are so safe and so effective, monitoring requirements are minimized, and this increases their feasibility in resource-limited settings. So let's begin with simplifying diagnostics. Currently, the first test is a screening test for HCV antibodies. Positive tests need to be confirmed with a hepatitis C viral load. However, these tests are expensive, they're not always available, it's extra work for the healthcare system, for the patient, for the medical provider, etc. So wouldn't it be great if it turns out to work to replace both these two tests with a core antigen testing, although there is still more data needed on how this can be implemented in resource-limited settings. And what about simplifying pre-treatment assessment? Well, generally, hepatitis C genotyping is a cornerstone of pretreatment assessment to inform both the regimen and the duration of treatment. And the other routine tests, pregnancy, looking at renal function, liver enzymes, etc., to assess someone's overall health. These can sometimes inform the selection of regimen. And staging of liver disease. But pan-genotypic regimens will allow us to skip genotyping. And routine and inexpensive blood tests can actually be used to stage liver disease, so you're left with these two groups of tests that will be much more cost-effective, probably around $25. And monitoring on treatment can really be simplified. So of course, safety monitoring is indicated by the person's overall health, and the regimen that you're using is going to remain a mainstay. But if you look at what the treatment guidelines are in Europe and the United States, both sets of guidelines recommend a baseline hepatitis C viral load. In Europe, a hepatitis C viral load at week 2 is recommended, and one at week 4 is recommended both in Europe and the United States. And part of the rationale for this is to check adherence. But that seems rather odd since there's a turnaround time to get these results. And if you find that someone is not taking their medications, it's probably after they've left your clinic. It may be very inconvenient for them to keep coming in and making these trips, as well as expensive and impractical. And some of the things that have been very successful with HIV, such as community health workers and peer support, could easily be used to really explain adherence to people and support it effectively and less expensively. Then the last test is a viral load at end of treatment. Now this won't tell you if someone's cured, but it will tell you if someone was not cured. But since people relapse, why not wait till 12 weeks post-treatment to really see if someone is indeed undetectable and they've been cured? So what about if you just got rid of all of these and kept these two as a way to radically simplify monitoring and increase its feasibility? And what are the drugs that allow us to do that? There are 4 classes of direct-acting antivirals: nucleoside and nucleotide polymerase inhibitors. These drugs are pan-genotypic or multi-genotypic. They're potent, they have a very high resistance barrier, and what's very interesting is it may be possible to recycle them in second-line regimens. Then there's NS5A inhibitors, which are also pan or multi-genotypic, potent, yet they have a low to moderate resistance barrier. Hopefully, the next generation will be more active against resistance-associated variants. Protease inhibitors are active against genotypes 1 and 4. They're potent, but also have a low to moderate resistance barrier. Next generation protease inhibitors may be pan-genotypic and have activity against resistant-associated variants. And last, they're the non-nucleoside polymerase inhibitors, which are active against genotype 1, but there doesn't seem to be much of a future for this class. So taking in mind that we have this menu of options, you can see what the clinical practice guidelines look like from the European Association for the Study of Liver Disease. They're incredibly thoughtful and evidence-based, but they're also quite complicated. The more complicated, the more opportunities there are for people to make mistakes, and the more complicated procurement becomes, etc. So while these are great guidelines, they're not suited for a resource-limited environment. So what do we really need? A target product profile for a first-line interferon-free regimen. And what would that look like? Those of you who were here this morning heard about Perfectavir. So this is my version of Perfectavir. Of course, safe, tolerable, and effective. And I really look first to cirrhosis. These are the people that may be treated first, that have an urgent need to be cured. And if it's safe, tolerable, and effective in people with cirrhosis, it will only be at least as effective, safe, and tolerable, if not more so, in non-cirrhotic people. So if you could aim for a cure rate of over 80%, and I think that's reasonable, that's part of an essential part of the target product profile. These drugs must be potent with a high genetic barrier and forgiving of mixed doses. And simple. They need to require very minimal assessment or monitoring. They should be once daily and preferably a fixed dose combination. The duration should be fixed also, no matter what genotype or liver disease stage a person has. No food requirements, temperature stable, and a 2-year shelf life. And universal. They should be pan-genotypic, and you should be able to use them in all populations, including people who are co-infected with HIV and hepatitis C, and with commonly used medications such as hormonal contraceptives, opioid substitution treatment, and others. And what you don't hear a lot is they should be strategic. We've got a bit of an embarrassment of riches. So why not think about what you're going to do next if what you do first doesn't work? And above all, they must be affordable, because it doesn't matter if they're all of these things if no one can get them. Fortunately, the generic drug makers have stepped in and offered people access to more affordable drugs in resource-limited settings, although there's still much more room for improvement and many barriers, which you'll hear about in the next speaker's talk. But there is Hopedavir. And also, let's look at what a package of diagnostics, monitoring, and treatment could look like. The very top white bar is inclusive of genotyping, but you can see that a 12-week or 24-week course of some of these drugs can be made quite inexpensively. In fact, sofosbuvir and decladisvir could be produced for about $177 per treatment course, including diagnostics and monitoring. However, I do want to point out that this does not include prevention, which is also going to be an important part of treatment programs for hepatitis C. So what are the limitations and knowledge gaps right about now? The first one is the development of incestuous combinations. Drug companies generally combine their own drugs and only use drugs from other sponsors if they don't have a candidate in their own stable. And this really prevents or hinders development of best-in-class DAA regimens and optimized fixed-dose combinations. Hopefully, we can rely on generic drug makers to really put together some optimized, not branded, fixed-dose combinations. Although millions of people have genotypes 5 and 6, data are limited, and they're also quite limited in common subtypes of other non-1 genotypes. NS5A resistance may limit the efficacy and effectiveness of these drugs, and it appears to be persistent, so it's quite a concern thinking about how you would protect this very valuable class of drugs. Cure rates are lower in people with cirrhosis, especially if they also have genotype 3. The treatment duration is still variable, which really complicates things. There's still a propensity for drug-drug interactions, although some regimens are easier to combine with other drugs than others. And there are many understudied or completely unstudied populations, including people who inject drugs during pregnancy and nursing, in pediatrics, and in many people with common comorbidities. And the other neglected areas, really thinking about what are the second line and retreatment strategies. It's a good idea to do this now to lay the groundwork for massive scale-up. So we've heard about Pefectavir, but we can't wait forever, and we can't make Pefectavir the enemy of Goodavir. We already do have Goodavir, and what that is a first-line regimen of sofosbuvir, a nucleotide, plus decladisvir, an NS5A inhibitor, plus or minus ribavirin. It's highly safe, effective, and pangenotypic. And what's in the pipeline in case this one doesn't work for somebody? There is a second-line pangenotypic protease inhibitor that could be used with a recycled nucleotide plus or minus ribavirin, although the data on this particular candidate is limited at present. And what about looking to the future in the pipeline? There is development of first-line pangenotypic triple-class regimens combining a protease inhibitor, an NS5A inhibitor, and a nucleotide. Now, this may be highly effective, but it leaves people who are not cured without really great retreatment options, particularly if they have NS5A resistance. So what we really need is a second-line pangenotypic regimen of super DAAs that are effective against NS5A and NS3 resistance-associated variants. So it's hard to say whether these are truly in the pipeline or just a pipe dream, because even though these drugs are quite remarkable, the more we know about them, the more we learn how to better use them and what their weaknesses may be. So in conclusion, direct-acting antivirals have dramatically simplified pretreatment assessment, monitoring before and after treatment, and actual hepatitis C treatment itself. However, the progress in hepatitis C treatment is not yet matched by advances in diagnostics. Possibly core antigen testing could replace HCV RNA, or there can be other rapid point-of-care diagnostics, but work is still needed in this field to optimize these diagnostic tools. And ideally, a first-line DAA regimen will be safe, tolerable, potent, simple, universal, strategic, and most of all, affordable, given what it costs to produce these drugs generically, and given the global disease burden. It seems really realistic to make it possible to do this for people. And these drugs actually can be really profitably mass-produced. You could get a whole package of diagnostics, monitoring, and treatment for less than US $200 per person. There are limitations too and gaps in knowledge about direct-acting antivirals, but these should not delay their implementation. Goodavir already exists, and more DAAs are coming. These drugs facilitate procurement and delivery of hepatitis C care and treatment, as well as acceptability among implementers, clinicians, and patients. Second-line treatment strategies should be considered as we queue up first-line regimens globally. And last of all, hepatitis C virus treatment is feasible in resource-limited settings and can be affordable. Thank you very much.